Hi friends, welcome to MedAce. I'm your pharmacology faculty, Dr. Arpit Agarwal, and today in this session we are going to discuss the pharmacology MCQ of the recently conducted INI-CET November 2024. So as you all have experienced in the exam, this time in the November INI-CET, the paper was, I would say, of moderate difficulty. Usually we expect a slightly difficult paper in INI-CET, especially in the November exam. But this time, the paper was, I would say, slightly on the expected lines. Most of the questions, particularly in pharmacology, that have been asked are either directly from our notes or they can be solved with the discussions that we have done in the various topics or the videos. So with that, let's have a look at the pharmacology MCQ. There were around 17 MCQs that were directly asked from pharmacology, and as you will see for yourself, most of them have been taken directly from my notes. So if you had gone through my lectures, videos, and read the notes, you would have been very comfortable in solving the pharmacology MCQ. So let's see what did we get in this INI-CET. First question from general pharmacology. It was a match the following questions. I've matched the options for you. Acetylcholine. Acetylcholine, we all know it has nicotinic receptor, and nicotinic receptors are a type of sodium channel ligand gated. Then growth hormone has enzyme link, particularly the JAK-STAT type of receptors. This was discussed. So do interferons, prolactin. Insulin has a tyrosine kinase type of receptor. This point has been asked, I don't know how many times already. So this was a simple. And the thyroid hormones have nuclear receptors that we all know. So it was a simple question, and I'm sure that all of you had attempted it correctly. Moving ahead, we got another question from pharmacology wherein you were asked to calculate the half-life. Now the data that was provided, that patient's body weight is 46 kg, the clearance of the drug is 4.6 liter per hour, and volume of distribution is 6 liter per kg. So VD was given in liter per kg. Now we have discussed very nicely in our lectures that T half is given by simply log of 2 multiplied by volume of distribution and divided by clearance. So simple formula. We have, I think, everything that we need to solve this. We can just put the values. Log of 2 you take roughly around 0.7. VD. Now VD, that was the only trick in the question. VD was given as liters per kg. So it was 6 liter per kg. And since the body weight is given, so we can multiply it by body weight to arrive at the total volume of distribution. And the clearance was given as 4.6 liters per hour. So you can now easily solve this. 4.6 will cross out 46 10 times. 6 into 10, 60 multiplied by 0.7. So you have 42 hours as the half-life. So it's a very simple based on the formula of the T half discussed in length, and I think a similar kind of numerical we also have in our lecture videos and also in the MCQs that have been provided in the MedAce app. So I'm sure it would have been a cakewalk for all of you. The next question. Now this question we have not been able to frame exactly. So what I could gather from the feedback from the students is that diastolic BP was reduced by. Now there is a confusion whether it was a single answer, single choice or multiple choice. But diastolic BP is reduced by 4 options: alpha 1 blocker, beta 1 agonist, smooth muscle relaxant, and the sympathetic outflow is cut from the lumbar side. Now diastolic BP certainly is not reduced by the beta 1 agonist. Beta 1 agonist, they will stimulate the heart. Systolic BP will go up, diastolic may also go up slightly. So certainly that will not help in reducing the diastolic BP. Alpha 1 blocker, will certainly cause vasodilation. If you block alpha 1 receptor, then vasodilation is going to occur. That will decrease the diastolic BP. So if you have to choose one answer here, then this will be the best. But then the option number C, smooth muscle relaxant, will also, by if you are going to relax the arterioles. So if you have a vasodilator, particularly arteriolar dilator, that will also reduce the diastolic BP, and sympathetic flow outcut can also reduce the diastolic BP. So I believe that the question would have been diastolic BP is reduced by all except, and then option number B would have been the best answer. But if the question was asked in the present format without except, then option number A, alpha 1 blocker, would have been the best answer. Next question was a clinical questions. Patients with history of diabetes, hypertension. He is already taking a statin, atorvastatin at 40 milligram. Now, total cholesterol, despite atorvastatin, total cholesterol is 240, triglyceride is 156, and HDL is 50. What all can be given? Now, we have discussed in our lecture that for a normal person, HDL should be above or equal to 50, which is the same. LDL cholesterol should be lower than 100. Triglyceride should be lower than 150, and total cholesterol should be lower than 200. So these values we have discussed in our video lectures. We all know that. Out of this, if I look at this patient, then his HDL is 50, which is okay. Triglyceride is 156, which is just above the normal range of 150. But the total cholesterol is still 240, which is much above the prescribed cutoff limit of 200. So I think what the question is trying to ask, that despite atorvastatin, the patient's total cholesterol is not under control. What all can be given? Now we have again discussed this in our lectures, that if despite the maximum statin therapy, high dose statin therapy, patient is not controlled, then you can add ezetimibe. Ezetimibe, we all know, is an NPC1L1 transporter inhibitor in intestine, decreases cholesterol absorption. Or we can try for PCSK9 inhibitors like alirocumab or evolocumab, they can be added. Or there is a new oral drug called bempedoic acid, which is also given. Bempedoic acid, again you will recall from the lectures, is an ATP citrate lyase enzyme inhibitor. Again, it acts in liver, decreases the HMG coenzyme A, and thus the cholesterol synthesis. So that can also be added to statin. So any of them can be added to an ongoing statin therapy to control the total or the LDL cholesterol. Gemfibrozil, we all know, is a fibrate, which are PPAR alpha agonist, and they are mainly used to decrease triglyceride. Now triglyceride in this question is already near the normal value, so I don't think there is any need to add a new medication to just control the triglyceride. So out of the given option, gemfibrozil is the one which should not be added at this point of time. Rest B, C and D, they can be added to this patient. Okay, so I hope you understand why we can exclude gemfibrozil based on the values given in the patient. Moving to the next question, which of the following causes adrenal suppression? Now this came directly from the endocrinology, anticorticosteroid. The answer we all know is an anesthetic, etomidate. I'll show you the picture taken directly from the MedAce pharmacology notes. Here you can see I had even given you a mnemonic keto, which stood for ketoconazole, etomidate, and a new drug, oscillodrostat. All these drugs, as you can see, inhibit the enzyme 11 beta hydroxylase in the adrenal cortex and decrease the adrenal hormone synthesis. So there you have, it's an anticorticosteroid drug, etomidate, although an anesthetic, but has this side effect. The other drugs that also inhibit the 11 beta hydroxylase and steroid synthesis are metiropone, which is drug of choice for Cushing's, and mitotane, which is the drug of choice for adrenocortical cancer. So clearly the question taken directly from the notes, and very simple question. Which drug causes slow inactivation of sodium channels? That was the next question. Now, there are several anti-epileptic drugs that inhibit the sodium channel, or more precisely, they increase the inactivated state. They increase the inactivated state of the sodium channels. They bind to the sodium channel in inactivated state and keep them inactivated. They include phenytoin, lamotrigine, carbamazepine. Now there is a new sodium channel blocker, lacosamide. Again, it's a sodium channel blocker, but what it does, it causes enhancement. It causes enhancement of the slow inactivation. Enhancement of the slow inactivation of the sodium channels. The drug is mainly used for focal or partial seizure, not a very important drug. So a theoretical question taken directly from the lectures. Lacosamide, new sodium channel blocker, increases the slow inactivated state of the sodium channels. So that is taken directly from, it's a fact based question, and we do see every year in INI-CET or in NEET PG that one question related to the mechanism of anti-epileptic drug is asked. So this time they have asked lacosamide. Remember, I hope you remember, a couple of years ago they had asked the same for a new drug, retigabin or izogabin, which is a potassium channel opener. So these kind of questions are expected. As I said, questions related to mechanism of anti-epileptic drugs are frequent. So we have another question that was asked, simple question. It was an image based question where GABA reuptake inhibitor was asked. Which of the drug inhibits the GAD transporter or the GABA reuptake inhibitor? So I have taken this image directly from the notes, and you can see here that GABA reuptake is shown. GABA reuptake is inhibited by the drug tiagabin, and that is your answer. Tiagabin, not a very commonly used drug nowadays, but it's unique that it inhibits the GABA reuptake. Some word finding difficulties or memory difficulties or memory problems are associated with this drug, so not a very commonly, but as you can see, the image was given. It was exactly the image that we have in our notes. So very simple question. Other drugs, ganaxolone is a neurosteroid, stiripentol has a barbiturate like action, lamotrigine has multiple actions including sodium channel blockade and including the decreased release of glutamate. So tiagabin, again, what we can see for future exam is that mechanism of, let's say, newer anti-epileptic drugs are particularly an important topic. Then we had again a question on match the following. Simple one. You are given 4 conditions and the drug of choice for them. So starting with delirium tremens, we all know benzodiazepines are the drug of choice for treatment. So oxazepam was given. Smoking cessation, the most effective drug for smoking cessation is a partial agonist on nicotinic receptor, varenicline. So that was given. Opioid overdose, we all know morphine, cocaine, morphine, heroin, or opioid overdose, IV naloxone, which is a mu receptor antagonist, that is the drug of choice. And for giving up alcohol de-addiction, we can use either an NMDA blocker, a camprosate, or you can use a mu opioid antagonist, that is naltrexone. So these are very simple, very commonly asked topics, and I'm sure that this question would not have caused any problem, especially if you have gone through my notes. Then the next question was comparing the parenteral iron formulation. So iron dextran is a conventional parenteral iron, and iron isomaltoside is one of the latest injectable forms of iron. Now this again was touched upon in our notes, as I will show you that older formulation iron dextran can be given both IV and IM, while the newer ones are only given IV. We all know iron sucrose, ferric carboxymaltose, or iron isomaltoside. With iron dextran, the most important problem clinically that we have to be aware they're highly immunogenic and a lot of hypersensitivity reactions are there. So one clinician while using iron dextran has to be very very careful about the possibility of hypersensitivity reaction. That's the main problem with this. The newer formulations are all having lower hypersensitivity reaction, including iron isomaltoside. So that is known. With that knowledge, you can try and attempt this question. It is more immunogenic than iron dextran. This is false, obviously. New formulation, less immunogenic, less hypersensitivity. Cannot be given with erythropoietin. Clinically, you should be able to exclude, because with erythropoietin, we sometimes need to give immediate source of iron, and parenteral irons all have to be given sometimes with erythropoietin. The only confusion could have been stored in adipocytes or single dose enough. Now see, iron maltoside can be given up to a dose of 1 gram, or let's say 20 milligram per kg IV, and the single dose is most of the time sufficient to correct the anemia. So that is the correct answer. That is the correct answer. It can, in a lot of cases, given IV up to a dose of 1 gram or 20 milligram per kg, and that is sufficient to correct the anemia. Stored in adipocyte is not. It is not stored in adipocyte. Actually, what it does, it releases iron very very slowly. It releases iron very very slowly, and that maintains the iron level for a very long time. So such is the binding of iron with the maltoside component, that's the carbohydrate component. So there is no storage in adipocyte. The correct answer is single dose is sufficient in most of the cases. Another question based on a relatively new drug. Now this question, again, we have not been able to frame exactly, but overall what was asked: Janus kinase inhibitor for inflammatory bowel disease. Now all Janus kinase inhibitor, they can be identified by the suffix nib. The name is going to end in nib. They are all oral drugs. Kinase inhibitor, Janus kinase or tyrosine kinase, they are all oral small molecules. Their name ends in nib. A similar question was asked in last year's INI-CET also, where you were asked a drug or oral nib inhibitor or tyrosine kinase inhibitor for cancer. So the trick, I hope you all are aware, is to find a drug that ends in the suffix nib. Now several options were given. These were three options: tofacitinib, ustekinumab, vedolizumab. Now any student should have been able to identify that mab means the drug is an monoclonal antibody. So ustekinumab can be used for inflammatory bowel disease, but it's a monoclonal antibody against interleukin 12 and 23. Vedolizumab is an anti-integrin antibody. So those can easily be ruled out. The only kinase inhibitor, Janus activated kinase inhibitor, which is given from the option is tofacitinib. So tofacitinib, again, as you can see, this I have taken directly from our notes, given as such: tofacitinib, baricitinib. These are oral Janus activated kinase inhibitor. Tofacitinib inhibits the Janus activated kinase 1 and 3, and bari, starting with B, which is the second alphabet, inhibits the Janus kinase 1 and 2. Both of them were initially used for rheumatoid arthritis, but tofacitinib is also used for inflammatory bowel disease. Baricitinib became popular both in MCQ as well as in clinical practice, briefly because of its potential role in COVID as well. So the question taken directly from the notes, had you gone through it, this question you would have solved 100% correctly. Moving to the next question, now we move on to the antimicrobials. Now all the questions in antimicrobials, and there were a few of them, have been taken directly from the notes. Directly, and I'll show you by giving the screenshots of my notes as well. Topical antifungal for onychomycosis. As if the question was taken directly from the notes. Onychomycosis is the dermatophyte of nail. As you all are aware, it's a nail infection by fungus. So as you can see, for the dermatophyte of nail, drug of choice is oral terbinafine. So it is clearly written terbinafine is to be given orally. If that is not available, itraconazole, again orally is. So itraconazole and terbinafine, they are given orally, and that helps you in ruling out them. Then previously, couple of years ago, they had asked that which of the drugs is available as a nail lacquer. Nail lacquer is a kind of paint, nail paint or nail polish. So this question was already asked. So this is an important topic, onychomycosis. Nail lacquer. So amorolfin and cyclopyroxalumin. These are the two drugs which can be applied as a nail paint or nail polish or nail lacquer. This question was asked. And other topical drugs that are available for treatment of onychomycosis. Now these questions have already been asked. They have not been asked recently, but previously when AIMS, not INICET, AIMS, PGI, JIPMER, different institute used to conduct their own exams, then this question was asked on a drug called efinaconazole. That is a topical drug available for, again, onychomycosis. This time they have asked tevaborole. So tevaborole is the topical drug which can be used for treatment of onychomycosis. As you can see, everything that you need to know in onychomycosis is given in such limited content. Directly questions are coming. Griseofulvin, we all know, is an oral drug given only for tinea capitis nowadays. High resistance already has been asked. Which drugs bind to CD4? CD4 on lymphocytes and also blocks the CCR5 and CXCR4 receptor. Now this is coming from the anti-HIV drugs. Anti-HIV drugs, ebalizumab, maraviroc, first temsavir. Several options were given. Again, you see, in order to understand, this is the HIV virus. It has a glycoprotein 120 on its surface, which binds to the CD4 antigen on the T lymphocytes. Clearly shown. Which drug shown by the number 1? Monoclonal antibody as shown binding to CD4. Number 1 is ebalizumab. So ebalizumab is a monoclonal antibody against CD4 given IV once in 2 weeks. That is the answer to this particular question. The other options that are given, number 2, there is a drug called fostemsavir. It's an oral drug which does not bind to CD4 as shown in the diagram. It binds to the GP120, the antigen on the HIV. And the third option given, maraviroc, is going to bind to the CCR5 receptor, again on the T lymphocyte. So all 3 drugs which are given in the options are shown clearly one by one with the diagram. You could have easily solved which drugs bind to CD4. Ebalizumab, that's the only CD4 binding drug. It also, after binding to CD4, it also prevents the binding of HIV virus to the CCR5 and CXCR4 receptor. So that's an additional mechanism, but it's an IV given drug for multi-drug resistant cases of HIV. So again, a direct question from the notes, from the diagram. So I hope all the MedAce students would have found this question very simple and direct from the notes. Which drug from the given option is not used in the treatment of uncomplicated malaria? If this question was asked in this format with these options, then this is a wrong question. There is no doubt about it. If there were some changes, then we can discuss that. But uncomplicated malaria, first of all, we have to understand, when we say uncomplicated malaria, it could be Vivex, it could be falciparum. There is no way for us to exclude Vivex or falciparum from uncomplicated malaria. For Vivex, we know that chloroquine is given for 3 days plus primaquine is given for 14 days. Both are needed. Primaquine is given mainly as a radical cure, so that would prevent relapse. That is not given for actual fever, that is only to prevent relapse. For falciparum, we give artemisinin combination therapy. We all know the common artemisinin combination therapy in most parts of India is a combination of artesunate given for 3 days plus a single tablet of sulfadoxine pyrimethamine. And especially in northeastern parts of India, because of the prevailing resistance pattern, we give a combination of artemether plus lumefantrine. phentrine. This both the drugs can have single tablet given for 3 days. So this is the treatment of uncomplicated malaria, the drugs that are used. Now let's look at the options. Chloroquine has to be given for 5x, primaquine has to be given for 5x. Artemether has to be given especially in northeastern parts, and sulfadoxine pyrimethamine has to be added to artesunate in most parts of India. So as I have shown you, if the question was asked in this particular format only, then there was no single answer to this. If suppose it was asked uncomplicated falciparum malaria, suppose if falciparum was given, then chloroquine has no role in the treatment of falciparum malaria, and that could have been the answer. But then you will ask, sir, there is no primaquine also in falciparum, why not primaquine? So you have to remember, no matter what ACT we give, a single dose of primaquine on day 2 has to be given as a gametocidal agent. In all falciparum cases, one single dose of primaquine has to be given on day 2 as a gametocidal. So if it was uncomplicated falciparum malaria, then chloroquine would have been the best answer. If suppose the question was asked without falciparum or Vivex mention in this format, then, and if you have to choose, then primaquine would have been the best possible option, although not correct, but best option, because primaquine actually is given either as radical cure or gametocidal. The patient would actually recover even without this drug if it is uncomplicated malaria. So that is the explanation. Despite asking several students, all said that this is the question that was asked. So I'm not sure if the NB made any mistake here, but I've given you various scenarios and the explanation. Next question, direct question from NT Helminth. NT Helminth, remember, is not a very commonly asked topic, but this time they've asked treatment of fasciola hepatica or the liver fluke. Direct fact-based question, as you can see, fasciola hepatica, from the notes I've taken, drug of choice is triclebendazole. If that is not given in the option or not available, then bethunal, one of them has to be used. Triclebendazole was given. It's an albendazole-like drug, inhibits the polymerization of tubulin, and fasciola hepatica can be treated. We all know that normally praziquantel is the drug for all cystodes and trematodes. For tapeworms and flukes, the drug of choice is praziquantel. Only two exceptions are there. If it is echinococcus or hydrated cyst in tapeworms, then we give albendazole, and if it is a liver fluke, then we give triclebendazole or bethunal. Otherwise, for all tapeworms and flukes, praziquantel is the best drug of choice. Next question about a new anti-TB drug, pretomanid. Pretomanid is a new anti-TB drug. The important new TB drug that has been asked several times in the recent past, is bedaquiline. So bedaquiline, since it has been asked, so it is very natural that they move on to some other new TB drug, and since TB is very important in India, so pretomanid has been asked. What is true about pretomanid? Acts by reactive oxygen species or oxygen free radical. This is partially true. What pretomanid actually does, it acts as a kind of nitric oxide donor. So the drug is reduced inside the body. After reduction, it becomes active, releases nitric oxide. Nitric oxide, through some free radical damage, ultimately affects mycolic acid synthesis. So mycolic acid synthesis is inhibited. That is believed to be its main mechanism. But I said it involves some free radical damage. So this we will keep as a possible option, although this is not the most accurate description of its mechanism. Used in XDR TB along with bedaquiline and linezolid. Now whenever we see this option, this is definitely correct. We all know that there is a regimen called BPAL regimen consisting of bedaquiline, pretomanid and linezolid. which has been approved for XDR-TB and even for MDR-TB. And now since we're talking, recently Government of India has made this BPAL as BPALM, including moxifloxacin also. And now this BPALM regimen, bedaquiline, predominant, linezolid and moxifloxacin, is being implemented in India for MDR-TB, 6 to 9 months complete oral treatment. So predominant has always been used in BPAL. It's not used in malaria, and there is nothing with CYP219 inducer. Same thing came directly from the notes. As you can see, nitroimidazole is the class to which delaminid and predominant drugs belong. Mycolic acid synthesis is their main mechanism. They affect the mycolic acid or the cell wall synthesis. Free radical damage is involved, and BPAL regimen was shown as it is for XDR-TB. So question coming directly from the notes. Again, clear example. So if you read my notes, listen to the video, solve MCQ, 95% of the question always come from that. So as far as pharmacology is concerned, as you can see, you need not look beyond Manipal MedAce. Not effective in preventing COVID-19. Now, COVID-19 is a topic that has been so widely discussed in medicine, in surgery, in pediatrics, in pharmacology. I am not aware of any subject where COVID-19 is not discussed, and we all know a lot of things about COVID-19. This was actually, I would say, a general knowledge question. Not effective in preventing. We all know vaccines have been very effective. Covishield, we all have got. Mask, obviously. Cough etiquette. So how to cough and how not to cough and what are the precautions, they also are effective. Ivermectin is a drug that was tried especially in India and Bangladesh in treatment of COVID-19, and initially this antihelminthic drug was thought to have some beneficial effect, but over the years clinical trials have shown clearly that it has no role in either treatment or prevention. So that was the answer. Then there was a question from the anti-cancer. Which of the following is a PARP inhibitor? Poly-ADP ribose, poly-ADP ribose phosphate. This enzyme is involved in DNA repair, and we are inhibiting this enzyme by giving some drugs, and all of them end in PARP. Poly-ADP ribose inhibitor, PARP. So any drugs which are ending with the suffix PARP, poly-ADP ribose. So it is very, very clear that olaparib or rucaparib, these are PARP inhibitor. They are mainly used in cancer of ovary. So very, very simple question. Again, directly from the video lectures. Cyclib, if this option was given, cyclib are cyclin dependent kinase inhibitor. Palbociclib is a CDK4 and 6 inhibitor. It stops the progression of the cell from G1 to S phase, mainly used in cancer of breast. So this was PARP or PARP inhibitor. I would say a relatively newer type of anti-cancer drug, and we always get one question on a new anti-cancer drug in INI-CET. So this was that question, but this time they've asked a relatively simpler one. And that's all we had in pharmacology. So all the questions, or most of them, came directly from my lectures and notes. So I am very, very hopeful that you would have found this paper relatively, I would say, of moderate difficulty, and you would have attempted it nicely, and I'm sure all of you would have an excellent result. So all the best for your result, and keep learning. Thank you.